What's going on, everybody? It's Doctor Bhatti here with Abdullah Chaudhry, the one and only. No, just kidding. We can cut this off.
Radiology is one of the few specialties that touches nearly every corner of medicine, from emergency care and chronic disease to cancer detection and prevention. Yet, for a field that plays such a central role in decision making, radiology often happens quietly. Patients may never meet their radiologist, but the interpretations made in imaging rooms shapes diagnoses, treatments, and outcomes every single day. Today on Doctor Diaries, we're welcomed by Dr. Irfan Bhatti, a radiologist whose work sits at the intersection of medicine, technology, and clinical judgment. Dr. Bhatti, thank you so much for being here today.
Thank you for having me, Abdullah.
Okay, so to start us off, what originally drew you to radiology, and at what point did you realize that this specialty was fit for you as a physician?
So, I don't know if I've told anybody this before, but I was actually interested in radiology uh, before even getting into medical school. I was always kind of more introverted, and I knew that I wanted something that wasn't super patient facing. And I kind of had an idea in my head that radiology would be a good fit because um, because of the diagnostic aspect of it. Pathology and radiology are primarily diagnostic fields, whereas other fields in medicine are more treatment oriented. And I liked kind of the problem solving nature of what I thought radiology would be about. Um, I was a little bit about my background. I was a math major in college. I My father actually was a professor of engineering, or is a professor of engineering, and I always enjoyed mathematics, and he'd you know have us doing calculus over the summer in high school, and really fostered a love for math with me and my siblings, and so it was kind of a no-brainer for me to major in math. I wanted to follow suit and go into academia, uh, but when I got to college, I felt that it was just too difficult of a road to go into medicine. Essentially, because I felt that while academia required hard work and maybe a little bit of luck, or maybe more hard work than medicine, I knew that if I just put my head down and did the work, I'd be able uh, to make it, so to speak.
hmm And when people outside of medicine often hear the term or the phrase radiologist, they often imagine someone who's just reading scans. So, how would you explain your role in patient care?
So I actually am that radiologist who's pretty much just reading scans. I Like I mentioned, did not want a super uh, patient facing role, and I decided to go the teleradiology route. So I work remotely and don't go into the hospital. But the cool thing about radiology is that you can kind of pick and choose uh, your lifestyle, so to speak, depending on your interests. So if you're someone who really likes being in clinic and seeing patients, breast radiology is an amazing field. You get uh, to interface with patients at a very vulnerable time. You do a lot of hands-on biopsies. You do a lot of patient counseling. Um, you almost have kind of a dermatology type lifestyle where you're seeing a ton of patients in clinic. You're um, doing a lot of minor procedures and you're kind of working chill hours, so to speak. If you like more, hardcore procedures and you fancy yourself a um, a surgeon light, you can always go into interventional radiology. Um, Interventional radiology spans what they call light IR, where you're doing basic procedures like thoracenteses, paracenteses, CT guided biopsies, ultrasound guided biopsies, to more invasive catheter directed treatment like angiograms of the head and neck in patients suspected of having strokes or ablations of liver tumors. So the spectrum's pretty broad, and I think that regardless of what drew you to medicine, you can kind of find your niche in radiology within one of the many subspecialties.
That's beautiful. And as you're saying, radiology spans such a wide spectrum. So some you'd be looking at trauma, stroke, infection, chronic diseases, cancer, even musculoskeletal injuries. So what does that look like for you in your day-to-day work?
Yeah, that's a great question. So I consider my areas of expertise to be neuroradiology and musculoskeletal imaging, and uh, that's primarily because those are my areas of interest, and so those are the areas that I focused most of my time in terms of reading cases on the clinical side, and then doing uh, continued medical education specifically in those areas. In residency, we're exposed to and get training in the entire gamut of radiology, but it's such a broad field. It's hard to practice each area at a really high level, and so I think focusing on two or three areas, maybe even one to three areas, and really honing in on pathology and anatomy and imaging in those areas uh, is is helpful. If you go into academia, you'll probably be reading in one subspecialty. I'm in private practice, or I guess I don't work for at a private practice, but I'm non-academic, and so I work one third of the time as a general radiologist, one third of the time um, as a and one third of the time reading neuroradiology, and one third of the time reading musculoskeletal imaging.
Is there a case that you've seen that fundamentally changed the way that you approach responsibility and decision making as a radiologist?
That's a really good question. I think that I wouldn't be able to pinpoint one case necessarily, but definitely the type of study that keeps me and I think a lot of radiologists up at night is CT angiograms of the head and neck. We read a lot of those, often ordered from the emergency room, looking for patients who are having a stroke, and basically, we're trying to detect tiny little emboli that are shot up from the heart or from the carotids that get lodged in these really small intracranial vessels. Uh, and then also we're looking for dissections in the major arteries in the neck. And the findings can be very subtle, but they can have profound treatment implications. If we if we miss something, it can mean the difference between a patient getting aggressive stroke therapy or not. and the patient may not die from the untreated stroke, but they could, and they could also potentially instead have um, pretty terrible morbidity and lifelong disability as a result of the stroke. So those cases are cases where I've seen misses that have medical legal implications, but more importantly than that, than the legal aspect, uh, the kind of consequences to the patient uh, when we don't catch those.
I want to also talk about cancer imaging. So, obviously, cancer is a huge, high stake, and emotionally charged part of radiology. So, what's it like knowing that you might be or you may be the first physician to see findings that could significantly alter someone's life, whether it's cancer or another serious chronic diagnosis?
That's a great question. I think that one thing that's often underappreciated by physicians who are not radiologists is the fact that cancer uh, is the fact that we pick up incidental findings, some of which may be cancer, on seemingly innocuous studies or studies ordered for completely unrelated uh, pathology assessment. And so, one example of that is, we might get a CT of the shoulder uh, ordered, and it's ordered by an orthopedic physician who's basically using it to plan their arthroplasty or shoulder replacement because the patient has really bad end stage osteoarthritis. Well, as part of the shoulder CT, we'll catch a portion of the thorax as we're imaging, and um, it can it could be the case that the patient might have a little lung cancer or part of a lung cancer that's visible on that CT, uh, that um, that we end up picking up, and the patient might not have had any idea, and obviously the orthopedic surgeon uh, wasn't ordering the CT of the shoulder to look for a lung cancer. So that's kind of one way in which we interface with oncology, uh, kind of incidentaloma as we call them, and then the other is there's a known cancer or we found a cancer, and we're trying to stage it, and that's super important because staging essentially allows us to uh, give the patient their best shot at survival because we're guiding treatment. So uh, if we don't stage a cancer appropriately, the patient might be undertreated, which can increase morbidity and mortality. Whereas similarly, if we're not staging appropriately and we uh, go the other way, then we can risk being too aggressive with our treatment. And whether it's surgery, radiotherapy, chemotherapy, these all can have bad side effects.
Okay. Yeah, I lost this game, bro.
Bro, you just need to believe.
I'm cooked, bro. Good game.
GG's.
I also wanted to ask, radiologists often influence major medical decisions, and this can happen without meeting the patients directly. So, what ethical responsibilities can come with that kind of behind the scenes influence?
I guess the biggest thing is communication. Um, if there is a life-threatening finding, like a pneumothorax or something we see on a chest X-ray, we have to uh, notify the ordering provider as soon as we're able to, and document that we talk to them. Um, that is that is kind of the extent uh, of our role in that capacity. And we sometimes make good calls, sometimes end up saving patients' lives, but um, it's not really a field where you can bank on having those sorts of feel good interactions with patients. You kind of have to be okay with being the unsung hero at times, if you will.
How do you handle uncertainty in imaging, especially when your interpretation may set off a cascade of separate clinical decisions?
Yeah, I mean, it's pretty gnarly uh, how big an effect what we put in our reports can have. You know, saying this versus that could mean the difference between a patient getting just discharged home versus a patient being uh, sent to being transferred via helicopter to a quaternary care center. So you really have to be careful with what you say and how you say it, um, but also know the limitations of the imaging tools. Oftentimes, we can't make a diagnosis on one image, and we have to synthesize the information with the clinical context. So, having EMR access and electronic medical record access to be able to see labs and see clinical notes, um, and being able to touch base with clinicians and get their thoughts on what's going on is paramount. The other aspect of a single image or single imaging study not necessarily being the truth, or being able to give a definitive diagnosis is that often uh, oh, that was really bad of me. often uh, the often what we need is time, and so you know one imaging study may represent a single time point, um, and sometimes the best thing to do is to recommend a follow-up imaging study to see how the finding changes, and that can help determine if an imaging finding is likely a benign incidental process or actual pathology.
So, I've been reading some of the recent literature in journals like Academic Radiology, and they look at specifically how radiologists feel about artificial intelligence in real clinical practice. So, there were several qualitative studies that interviewed practicing radiologists, and they found a recurring theme of cautious optimism. They said that AI is seen as a powerful support tool, but not a full replacement for human judgment or clinical context. So, from your experience, does that reflect how radiologists truly view AI today? And where do you personally draw the line between helpful assistance and over reliance?
I think that that's a fair assessment. I mean, we're a heterogeneous bunch, so you'll have you know, a spectrum in terms of opinions on where AI is going and what it'll do to the field. You have some complete doomsday people, and then you have other people who think, that it's all hogwash, but probably the truth lies somewhere in the middle. I think that in its current state, the tools that I've used um, have probably been more of a hindrance than help. For example, one tool that I've used is a pulmonary nodule detection tool. So on uh, CTs of the chest, we always have to check for little ditzels that can measure, 6 millimeters or less, and they're tiny little white dots on a background of black air, um, that can be tedious to look for. And so I've used an AI tool that flags what it thinks are pulmonary nodules. Um, and and the issue with that tool is that it needs to be extremely sensitive, because you don't want it to you don't want to rely on a tool and it's missing pulmonary nodules. But inherently, when you ramp up the sensitivity on this tool, it limits the specificity. So it's flagging. You're getting a lot of false positives essentially. So it's flagging things that as pulmonary nodules that are just benign areas of fibroadelectasis, or that are a little benign intrapulmonary lymph nodes, for example. So I haven't been super impressed with what is currently available on the market, but the field is rapidly evolving, and who knows what tools will be available next year, in the next 5 years, in the next 10 years. I do think that there are inherent limitations to the technology. I mean, it's predicated on neural networks the same way uh, these LLMs like ChatGPT and whatnot are. And so the the issue that we get into with ChatGPT, for example, with hallucinations or with implicit biases, are not really um, going away, or I should say, I'm running out of time, so I'm fumbling over my words. But those issues are big issues with AI radiology tools, and uh, until we can solve those, I don't think um, that they'll be able to come anywhere close to replacing radiologists. The issue is that they don't need to be better than radiologists. Um, they just need people to think that uh,
That boy suffering.
they just ah! Oh man, I ran out of time. GG's. Um, they just need people to think that, like the general public or and hospital administrators and blah blah blah, whoever else, need buy-in. Like if the consensus is that they're good enough and the public trusts it enough, then it'll be able to replace radiologists to some degree, even if it's not actually uh, good enough or ready for prime time. And I mean, we see that with kids who forego learning how to write and develop critical thinking skills and just use AI to generate their persuasive essays in school. And with kids raised on, and this generation raised on ChatGPT, uh, I suspect that there'll be more and more acceptance of these AI tools without giving thought to uh, kind of the nuance of uh, when these tools should be applied or what the limitations are. So I guess all that to say, I don't think it really matters if the technology progresses or gets better, uh, because it seems like society is moving toward accepting it regardless.
So, for students or residents considering radiology, what should they consider when they think about this field?
I guess that kind of call back to what I said earlier about how there is something in radiology for everybody, whether you want to be a dedicated proceduralist, whether you love spending time with patients in clinic, whether you want to get away from kind of a more patient facing role. Uh, you can find something that you're interested in, and to expound on that a little bit. Uh, if you're specifically interested in an organ system or a part of medicine, you can also tailor your practice to that. So, let's say you go through your preclinicals and you love neuroanatomy, you go through your clinicals and you love neurology. Like neuroradiology may be a good fit for you. You don't have to be a neurologist. You don't have to be a neurosurgeon to deal with those same sets of pathologies. And um, I really enjoy sports medicine, but I didn't want to be an orthopedic surgeon or a physiatrist or a sports medicine doc. But I get a lot of satisfaction from reading MSK musculoskeletal MRIs of high-end athletes, for example. Um, so that breadth that we talked about earlier of radiology really works in your favor if you're uh, a prospective applicant, or if you're trying to figure out what residency you want to go into.
Another thing that I want to bring up was when your work quietly shapes outcomes but often goes unseen, what keeps you grounded and motivated on those difficult days?
I guess for me, it's not difficult from that aspect. Um, I didn't go into radiology or medicine at large for any sort of recognition or to have even uh, those type of feel good moments where I'm feeling like I make a difference. I think it can contribute to burnout in people who want that. And but I've also seen radiologists who do feel like they're making a difference, and those are generally uh, people who are very plugged in with their medical community, and who one particular example I'm thinking of was a mentor who was a well-known radiologist in a small town, and so he did a lot of biopsies and had a lot of patient contact, and also was a constant presence in the hospital. wasn't a remote guy like me, and the referring providers knew him by name, trusted his reads. Would He was kind of the go-to guy on a lot of cases, and so all those things uh, gave him a lot of personal satisfaction, and I think that can be helpful in preventing burnout.
I have ALEST, but I have no idea what this word is.
Hmm.
And I have made 3 mistakes so far. I have 3 more chances. So A
How,
L
does
E
it show
S
you
T.
how many letters the word is?
Yeah, it does show me.
I might have mistyped it. How many letters is it?
It is 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 letters.
Oh, okay.
Okay. Bro, this word is hard. I have Alest. Alest E.
Some, I'll give you another hint. Some might say it's not even a real word.
Wait, let me activate the hint. I haven't seen it yet. Let's see the hint.
Oh,
The hint is watermelon. Oh, that's great.
was that too obvious?
The hint was a little obvious, and I still made a mistake. Okay, so I got 70 points from that because I guessed it correctly. That was a good hint. All right, now I'm watching you guess my word.
Okay, I learned from you, and I just clicked hint right off the bat. Um, you know what's crazy is your hint is water. My hint was a watermelon, and
Oh
yours is
yeah.
water. All right. Guess we'll go for some vowels. Okay, getting cooked.
Oh. Oh. So I also
Okay.
wanted to ask another question. What's one thing that you wish patients understood or knew about radiology that most people who come to the hospital or most people who are going through imaging don't know?
I guess the limitations of the modalities, in terms of not being able to give a definitive diagnosis, uh, and also the limitations of us as humans. Um, we make mistakes every single day as radiologists, some of them catastrophic, most of them inconsequential. But we're trying our best and to do right by the patient, and part of that is reading cases in a timely manner. Volumes are insane, and there are always more scans that need to be read. And so, unfortunately, nobody can afford to spend an hour reading a brain MRI. Maybe most people would give 5 minutes for a stone cold normal one to 30 minutes for a super complex post-operative case where you have to dig through the notes and compare to multiple priors. Oh, you got me.
Yeah, the word was drought.
That's
I guess my word was a bit hard.
no, that's very apropos for Phoenix. So, uh, so yeah, basically, we're trying to balance accuracy and speed, both being important for patient care because, if we're too slow, then you have a queue of patients waiting in the ICU or in the ED in the emergency room for their imaging to be read, and some of those could have patients could have critical findings that need to be reported right away, uh, and that those two uh, those two things, speed and accuracy, are sometimes uh, clashing with one another, uh, and sometimes we have to read faster than we would like, um, due to volumes, due to pressure from hospital administrators, etc. Um, But just I guess realizing that we got into this profession to help people, and we really take that seriously. And even though a radiologist might miss something every single day, it doesn't mean that they aren't trying their best or they don't care. It's part of it is also just a numbers game. If you're reading 50 cases a day, the chances that you're going to miss something are not insignificant.
Is there anything that you want to add before we do the conclusion?
I'll just say that radiology is the best field. Everybody should go into it.
So, from everything that we've heard today, radiology may work in the background, but its influence is everywhere, from diagnosis to treatment and also to prevention. Dr. Bhatti, thank you again for sharing your perspective and helping explain to us the true responsibility of radiology.